Again, thanks for the introduction, Jessica, but the only thing I want to add, there's two things. So first, I want to shout out Hannah Wang. She is with our IT department at UT Health. She is the wizard who translated what we built in Excel into a beautiful user-friendly website that you're going to see a little bit later. And the other thing I want to point out is that, yes, I just got my PhD. I'm very excited about that. I just defended a few weeks back. But I think most importantly, I am a peer. So I'm a person in recovery from substance use disorder. I trained and was certified as a peer worker. In Texas, they're called peer recovery support specialists. That's the old credential, new credential name now. So I trained as a peer worker back in 2014, and I actually used those skills in a collegiate recovery program from 2014 to 2019. I ran the program at UT Austin for those years. I transitioned into the research world in 2019 because I felt like that's where I could make the most difference, building tools like this to help programs understand their economic impact a little bit better and to kind of make that information more accessible. But so really, like, I'm not coming at this from a peer research angle. I am coming at this as a peer, as somebody who has worked in peer services and who really hopes to make your job a little bit easier, hopefully, and to help you get funding and argue for why your programs matter and why they make a difference. Okay, so with all of that in mind, I want to give you an outline of what we're going to talk about for the rest of the day today, or for the rest of our session, not the rest of the day. Don't worry, I'm not going to keep you here that long. So I'm going to go over the background of the project and then kind of what we're working towards in the future. Then I'm going to spend a good chunk of time teaching you about cost effectiveness analysis. What do we mean when we say cost effective? I'm going to give you the results of a kind of a more detailed analysis I did of the peer recovery support services. Again, just for substance use, not for mental health. Though unfortunately, it's just for substance use. But I'll give you those results. And then we'll talk a little bit about how we built out the bystander naloxone distribution portion. And then we'll introduce the actual calculator tool, that nice, more user-friendly website that's free and just available for you to use. So you can kind of do your own analysis and then hopefully with this tutorial, interpret the results that you get from that. And again, you can download these slides at this link. Okay, so the ultimate goal that we're working towards, we want to build out a free web-based, multifaceted cost effectiveness calculator that helps to empower stakeholders, so recovery community organizations, advocates for recovery services, community decision makers, et cetera, to use cost effectiveness information, to interpret it, to use it to their advantage, to kind of demonstrate the need for more funding, et cetera. And we also hope that it increases support for existing programs, so peer recovery support services that are already in existence, and then maybe build support for adopting new programs as well. As a bonus goal, we will also be helping to fill in some of the major gaps in research that exist, because there's almost no economic evaluations of peer-driven substance use interventions. Pretty much all of the economic evaluations that are out there right now are of pharmaceutical interventions, so like medications for opioid use disorder, which are great and do a lot of good, but that's not the whole picture, right? And then we have some clinical interventions, like more traditional inpatient treatment. Some of those have also had economic evaluations, but it's pretty rare if it's outside of pharmaceutical, and then definitely outside of clinical as well. So we have a ton of gaps to plug, especially in recovery support services and especially in anything that is really peer driven. All right. Why are my slides not turning? There we go. Okay. So again, there's a lot of work to do. Back in 2018, I did a collegiate recovery program, cost effectiveness analysis, and published those results. And then I also built out a calculator But and you can follow this link. If you follow the link to the slides, you can click on this. It's going to take you to an Excel-based calculator, way less user-friendly. You know, I still try to color code things and make it a little bit easier to use. There's a lot of tutorials and other materials, but what we really want is something similar to what you're going to see today, something that's web-based, something where people don't have to open up a spreadsheet and see a bunch of ugly numbers that, you know, can look really overwhelming and kind of feel a little bit more intimidating than what you're going to see today. So I made that cost effectiveness calculator as part of my master's thesis work. But then during my doctoral program, you know, we found it was time to start looking for some funding to try to do this on a much larger scale and actually be able to pay somebody in IT to build out that web-based version for us and make it much more user-friendly. So we were able to do that. We got pilot funding from the Recovery Research Institute's pilot grant program, and that's through NIDA. So as the goals of that pilot grant, so this is kind of the micro project, right? We were going to do the underlying cost effectiveness evaluation for long-term peer recovery support services for substance use, and then combine that with bystander naloxone distribution. So there's an existing cost effectiveness analysis of that. What's naloxone? It's a pharmaceutical, right? So there had already been a cost effectiveness analysis of that. We needed to update it because it's about 10 years old. So we updated all those numbers. That was mainly Margaret Brandon Moore, or Marnie as she goes by. So she updated that. And then we built those into a cost effectiveness calculator. And then Hannah, of course, made it web-based. And then, of course, we are in the middle of, we've just completed this project. We're in the middle of working towards more funding to hopefully build out more components and make it something that's even more useful, where you can compare a bunch of different interventions. Okay, so let me walk you through kind of the flow of the study. We got that funding, great. We did some of the background research, and then we actually got feedback from 2 local Austin recovery community organizations called Communities for Recovery and Recovery ATX. And they sat down with us at 2 different points, here and here, and gave us some really important feedback. So the first round of feedback from the RCOs came at reviewing the analytic model. So how we were planning to put all of our numbers together and construct what we thought best represented how peer recovery support services work and how bystander and naloxone distribution works in an RCO setting in particular. So we got feedback on that model, we integrated that feedback, and then we made a prototype calculator, and then we had the RCOs test that prototype. We were able to integrate their feedback. You know, we'll see this when we see the calculator, but some questions were around like, is this a number that you think you could get, right? could you find this number pretty easily in the information that you already gather about your programs? And would you be able to plug this into a calculator, or would it be so much work to get that number that it's not worth it? So those kinds of questions. We finalized that calculator. We launched it at the National Association of Peer Supporters Conference back in October. And then we've been gathering feedback on that pilot calculator ever since. We put up a survey to get feedback. We, of course, invite any emailed comments and all sorts of stuff. So very much still welcome to feedback. It will definitely help us make this as useful a tool as possible to you. Okay, so we've talked about the background. We are going to move into kind of the tutorial section. So again, this is going to be, this is going to feel maybe a little bit fast. It's going to feel like we're moving pretty quickly. I will just say, I am not trying to get you to a point where you feel like you can do a cost effectiveness analysis. Don't need to worry about that. That would take you a whole semester of college. So that's not what we're trying to do. But I want you to be able to use the calculator and then have a little bit more understanding about what is this result telling me, If I want to use the calculator and use those results, what would I write in my grant proposal or in my report to support these numbers that I'm getting from this calculator, right? How do I interpret this information and use it to benefit my program? Okay. On the calculator website, there is a longer version of this tutorial, and there's also some additional resources, but you are definitely welcome to download these slides as well. The notes section of each slide has very similar to what I'm saying right now. So, so you'll have most of this information. Okay, so let's answer this first basic question. What is cost effectiveness analysis? So it's a type of economic evaluation. And we do economic evaluations to find out for any intervention or program or activity that we want to do for the benefit of society, we want to know about the resources that go into that intervention that make it happen. And we want to know about the good stuff that comes out of our intervention that's produced by that intervention. So economic evaluations of various kinds tell us what is the balance between the resources in and the good stuff out of our intervention. And there are multiple ways to find out about that balance. We can do cost effectiveness analysis. We can do cost benefit analysis. You've probably heard that term before. Or you might do a type of analysis called return on investment. These are all terms that you've probably heard kicked around out there, right? Now, cost benefit analysis and return on investment are both a type of method that involves putting a dollar value on that resources side and putting a dollar value on that good stuff side. So they put a dollar sign next to the outcomes of an intervention, the good stuff produced. So in our case, like recovery produced, right? What's the cost of the benefit of recovery? I think that's a little bit tricky. And we're also kind of in this, especially on the substance use side, I'm sure there's similar conversations on the mental health side as well. I'm just more familiar with the substance use side. There's conversations about what is recovery? How do we define it? What are the hallmarks of it? So I feel a little bit weird about methods that that force you to assign a dollar value to the good stuff when we're talking about recovery, because I don't feel like we're 100% there yet with a really solid way to define and operationalize recovery, right? So that's why I really like cost effectiveness as a method. Cost effectiveness involves, sure, you still put a dollar value on the resources in, that's a little bit easier, right? But you don't put a dollar value on the good stuff that comes out of the intervention. So that's why I gravitate towards cost effectiveness. I know that when it comes to legislators, I think they tend to talk more in terms of cost benefit or return on investment, at least in this country. In the UK, Australia, places in Europe, cost effectiveness is actually the kind of the preferred method. But you know, you see some of all three of these, and they're all still very useful. I just find cost effectiveness to be especially useful when we're talking about recovery. Okay, so in cost effectiveness, we are doing a bunch of math to try to get to this end result called the incremental cost effectiveness ratio, or ICER. That is telling us the price of our intervention for every unit of good stuff that comes out of our intervention. Now that sounds kind of funky. So we're going to walk through kind of a more everyday example to try to help us think about it and try to make sense of it, right? Sometimes really useful to have metaphors. So we're going to use the grocery store metaphor. So when you go into the grocery store, if you are trying to make sure you're spending your dollars wisely, maybe you're on a budget and you want to stick to it, we often compare sticker prices, but comparing sticker prices alone is actually not giving us the whole picture. And so grocery stores actually give us a tool to make a different kind of comparison, especially when the packaging is not identical, the product is maybe different, but kind of similar. So we can compare price per ounce, price per pound, some kind of price per unit, right? So let's say I'm trying to decide between name brand Cheerios in a 15-ounce box, right? And generic oat brand cereal in a 12-ounce box. The sticker price for the generic is cheaper, sure, but it's also in a smaller box. So how do I make sure that it's actually a better deal? I look at the price per ounce, right? So I see the generic is 20 cents per ounce. The name brand is 26 cents per ounce. Okay, cool. Oat brand is the cheaper. That's how I'm maximizing my units of breakfast for every dollar that I spend, right? So I can also compare different sizes of exactly the same product. And we would call that economies of scale. So I kind of assume, I think most of us would assume that if we walk into a place like Costco or Sam's Club, where you have the really big sizes of everything, that the bigger size is going to be a lower cost per ounce compared to the smaller size. But that's not always the case. Just like in, interventions, maybe a program works really, really well when it's like 20 people that you're serving, but it kind of breaks down or becomes inefficient when you're trying to serve 150 people, right? So economies of scale, cost effectiveness lets us look at those kinds of questions too. Same intervention, just different sizes. So in this example, we've got our 35-ounce and our 44-ounce bottles of ketchup, and wouldn't you know it, the smaller bottle is actually more cost effective. It has a lower cost per ounce than the ketchup, the larger ketchup. Okay, so let's go back to our math now that we've walked through kind of a more everyday example. So let's put that in terms of health interventions, right? So let's use an example of quitting tobacco. We might express our result, our ICER, as this program costs $100 for every person quitting tobacco. Or let's say it's a vaccine or a medicine. It costs $20 per every averted sick day. We'll get into this a little bit more in a second. We will be using the term quality adjusted life year or quality adjusted year of life. That's going to be a common term that you see in cost effectiveness as well. And we'll explain more about what that means in a minute. So you might see, the number that you're getting, that single number that you get as a result. That's great. Just know that it's basically a cost per ounce. It's whatever unit of good stuff that we're thinking about in that analysis. Okay, so this is our formula that we use to find our ICER, our result. We look for the difference between the cost of an intervention, so peer recovery support services, bystander naloxone distribution, the thing that we're looking at that we're most interested in. How much does that cost compared to whatever it is that we're doing right now? Treatment as usual. What do people typically get that is kind of the go-to instead of whatever kind of new or more cutting edge intervention that we're trying to analyze? So with peer recovery support services for substance use, well, maybe they're getting specialty treatment in kind of the best case scenario and nothing else. For bystander naloxone distribution, well, they're not getting it from a bystander, like somebody standing next to you who happens to be witnessing an overdose. They're going to have to wait until EMS arrives, right? So we'd be comparing that. That would be treatment as usual. So we find that difference in the costs, the resources in, and then we divide that by a difference in effects, good stuff that comes out. And so it's always a difference between the new thing that we're looking at and in comparison to the old thing that we're used to doing. Okay. So let's talk about how we figure out the good stuff, this bottom part of our equation. So again, we don't assign a dollar value to this. We just let it stay in that unit that it's already in, right? We always have to do quality adjusted life years. And that's because health economists always use this measure, right? They always use this kind of unit. So just like in my serial example, if I want to compare peer recovery support services cost effectiveness to the cost effectiveness of, oh, I don't know, something like horseback riding therapy, right? Equestrian therapy. If somebody had done a study, I don't think anybody's done a study on that, but it's a pretty different type of intervention, right? Using quality adjusted life years as my common unit allows me to compare those interventions more directly, right? Just like comparing Cheerios to to generic brand oat bran cereal, right? So I always have to do that. Now, what is a QALY? So let's imagine, so kind of as the name suggests, I'm trying to capture the quality of my life, in addition to the number of life years added. So like, let's say I have a cancer intervention that extends my life by 5 years. That's great. But let's say it's also really, really difficult to go through that treatment. And, maybe it makes somebody feel really ill. They can't get around as well. It really impacts the quality of their life. Well, we need to have a numeric way of capturing that rather than just capturing those 5 years. We want to represent the impact of that treatment on those 5 years, right? So we do that with QALYs, with quality adjusted life years. So if we had perfect health for 4 years, perfect health is represented by a quality of life weight of 1. 1, there's no changes, doing great. So 4 times 1, 4 years times a weight of 1 is 4 quality adjusted life years. If I am only about at half of my quality of life, then I would use 0.5. I'd multiply 4 by 0.5, and that would give me 2, right? So I have half as many quality adjusted life years as perfect health. So it's not a super intuitive concept, but it is something that's necessary for health economists and to compare to other kinds of interventions that we might be asked to compare to. Now, we also want to do something that is a little bit more intuitive and that makes a lot more sense for our specific intervention, the field, the audience that we're speaking to. So we always want to do those quality adjusted life years, but then also something that's meaningful and more easy to interpret. So the example I gave here is directly relevant to what we're going to be talking about with the calculator. We looked at additional people in recovery. And then for naloxone, we looked at for every additional life saved, right? So when we put it in terms of individual people or individual lives, that can be really helpful. It's a little bit more intuitive than quality adjusted life years. Okay. So let's talk about how we figure out costs, this top part of our equation. Again, dollar value assigned to all of that, that's our resources in, right? We want to look at costs in at least 2 different ways because there are kind of 2 different ways that it might impact people, right? So we always want to look at societal. How is this, what kind of resources from all of society go into this? So this is where you want to think about stuff like, my organization might, pay this many staff people. Okay, great. But then maybe we also maintain a pretty big fleet of volunteers. In the societal costs, we actually want to think about the amount of time that those volunteers spend with us when they could be doing something else, right? They could be working their own job or, working a second job, or just enjoying their leisure time, right? So we want to make sure we account for the time of volunteers. We actually account for stuff like participant time as well. So somebody who's coming to your organization for peer recovery support services, if they're coming, roughly once a week for an hour at a time, we actually want to capture their time costs in this side too. It might also include things like criminal justice costs. impacts on home, on family. It does also include medical costs, education costs, just kind of this big global picture, right? And then we also want to think smaller as well. We call this the health system perspective, but you can kind of think about it as whatever kind of unit makes sense, right? For the calculator, we went ahead and defined what the health system is for everybody, right? But I'll just give the example of when I was doing that collegiate recovery program cost effectiveness analysis, I actually defined that health system as an individual unit or individual institution of higher education, an individual college or university, because they're the ones who are kind of responsible for maybe meeting that student's needs. If the student drops out of college, that's a cost to the university, right? So we, they're kind of an interested party there. They're kind of the health system in that situation. So it's flexible, but it needs to be something meaningful as well. So for our example, the calculator that you're going to look at today, for peer recovery support services, we're looking at the medical system, which includes things like specialty treatment, hospitals, things like that, but it is limited to kind of a more traditional understanding of the healthcare system. And same thing for bystander naloxone distribution, because of course, where do people tend to go when they experience an overdose or something like that? To hospitals, right? So for those two, it made more sense to kind of stick to that traditional definition. But if you encounter, cost effectiveness in the future, just keep that in mind. It might be it might be something a little bit more flexible. Okay, so I'm going to recap what we just went over. We have two different ways that we put a dollar value on this top part. We have that societal and health system perspective, right? One is really big, looking at everything. One is much more narrow, looking just at the health system or whatever you want to define. And then we don't put a dollar value on this bottom part, on the effect part, the good stuff, the outcome. No dollar value put on that. And then we also want to look at it at least in terms of quality adjusted life years, right? So this intervention probably adds more years to your life. Great, we want to look at that. But then we also want to pick something that makes more sense to our stakeholders, that's more meaningful, more interpretable. Okay, so that means since we have two different ways of looking at it here and two different ways of looking at things here, we're going to have at least two results, ICERs. We might have as many as 4 or even more if we wanted to look at it different ways. So for the calculator, we're going to have 4 different ways of looking at it. We've got societal, health system, societal with qualities, societal with people, and then health system, qualities, health system, people. Okay. Before I go into interpreting the result, are there any questions at this point about just kind of what goes into the setup and the thought processes behind it? Okay. So let's talk about interpreting our results. You've got kind of the gist of what goes into setting up these kinds of analyses. Now here's kind of where we're going to talk about how we can actually use them, how we would interpret them, what's a good result to get. So remember, it might look like we have like a single number. When you get the calculator results, it might look like just, one individual number. Okay, but what we're actually talking about is a ratio. So it's over 1, and the 1 is 1 unit of good stuff. So 1 unit of our outcome. So 1 quality adjusted life year or 1 additional person in recovery, right? Now, we compare that result, that cost per unit of good stuff, we compare it to some preset numbers that we are pretty sure the government would be willing to pay. That's kind of the history of like why we have these preset numbers. We call those numbers the willingness to pay threshold. So the standard, like established, health economists use these all the time. Those numbers are 50,000, 100,000, and 200,000 for every quality adjusted life year. And those numbers, the history of those, this is kind of fun. So the history is that back in the 70s, when they were basically adding dialysis for end-stage renal disease to publicly funded healthcare, Medicaid, Medicare, this is what 1 year of dialysis cost back in the 70s. So since the government was agreeing to pay for it under Medicaid and Medicare, that means that we know the government will pay at least that much, right? These additional numbers are representative of inflation since that time. So we still kind of use these by convention. Again, this is kind of health economist stuff. We also want to do something that is meaningful to our audience, right? So we might choose another number. Typically, we want to choose something that's lower than these government thresholds, right? So we might choose the cost of another round of specialty inpatient substance use disorder treatment, right? It's pretty expensive, but it's not quite $50,000 expensive, at least not typically. We might choose the cost of an ICU visit for an overdose event, right? So some kind of meaningful number where if we can compare our result to that number and it makes a little bit more sense, right? So if our result is less than any of those thresholds, then it's cost effective. If it's a little bit, so it's easier to pass the higher numbers and it's harder to pass these smaller numbers. So if it's past the smallest threshold, then it's extra cost effective, essentially, right? Because it had to make it through each of these levels, right? And it can be cost effective to one threshold, but not another. So let's say it's cost effective. Let's say our result is 49,000. Well, it's not cost effective to the very lowest one that we set, but it is cost effective to that $50,000 one, the first of the government ones, right? Okay. And this is where it starts to get fun, but also a little bit weird. So if you get a negative result, fantastic. This is actually really great news, but only if there's one circumstance going on. And our calculator will actually tell you if it's not this way. But if it's negative, then that means it's cost saving and cost effective, which is really great news. But it has to be negative for this one specific reason. If the intervention costs less, so the top is negative, but the intervention still does more good, so the bottom is positive, then you're in business. And that's because, here, let me go back. That's because if our intervention cost more, but also didn't produce as much good stuff, then yeah, that's not great, right? We don't want it to be negative for that reason. That would still give us a negative number though. So our calculator has a little logic check in it where it won't say yes. It gives you some plain language feedback like, yes, it's cost effective and cost saving. That little box will just say no. So it needs to be negative for this reason, but if it is, then it's good news. But I will say, just because it always bears repeating, the intervention does not have to be cost saving specifically in order to be cost effective. Cost effective and cost saving are two different things. It's great when they're both, but it's okay if it's a positive number. If it's still cost effective, then that's still good news. So this is just a little recap. We compare our result to these thresholds. It's cost effective to whatever threshold the number falls below. And if it's below 0, because costs are less, but effects are better, then it's both cost saving and cost effective. So at this point, are there any questions before I move into the next section? Okay. So the next section we do have some uncertainty in some of these, in some of the numbers that we're plugging in, right? Whenever we build out these analyses, whenever we build out the calculator, there's going to be some uncertainty. Different studies find different results, right? Different outcomes. Wages are higher in different parts of the country than they are in others, right? So when we don't look at any of that kind of uncertainty or variation, that's the base case. That's the calculator. We're just looking at like a snapshot in time for one place. When we are able to look at the variation of one variable at a time, that's called one-way sensitivity analysis. And you can actually do this with the calculator. What you would do is you'd type in inputs for one scenario. And let's say you want to see what happens when you raise wages within your organization. You would jot down the results, then you would just rerun it with the new proposed wage and see what it did to those results and jot that down again, right? So you can do a version of this with the calculator. We definitely do this for the analyses that we're doing for research purposes. And then this one, we're really only doing this for like a full evaluation or for research purposes for academic papers. That's a probabilistic sensitivity analysis. That's basically, we're looking at all the variation, all the uncertainty, all at once, and seeing what happens when we allow everything to vary over time. So you can't do that with a calculator, but don't worry, I did it for my study and I'll show you the results. So I'm going to walk you through the results of the underlying study that I did really briefly. I think, so we walked through how we find our incremental cost effectiveness ratio. Again, it's a difference in costs between our new intervention and treatment as usual. We divide that by a difference in effects. One thing that I think is really important to point out is that treatment as usual for substance use is typically nothing, right? Like 90% of people with substance use disorder don't get any kind of treatment in a given year, let alone specialty treatment. But it's really not a fair comparison to compare your intervention to doing nothing, because typically everything's going to look better than doing nothing, right? Just about anything will look better than doing nothing. So we set kind of an artificially high starting point, and that is specialty substance use disorder treatment. So we know that not everybody who engages in peer recovery support services has gone to treatment first. One of the things we'd like to build out in the future is to be able to let people kind of play with that a little bit, like 10% come to us from treatment, 30% go to treatment because of us, 50% bypass treatment altogether, right? Like we want to be able to have that kind of subtlety. We don't yet. I just wanted to start with the most conservative way of estimating this so that we can say, hey, here's our results when you give it like the most conservative, the most rosy picture, kind of compare PRSS to the most ideal scenario, right? So this is going to be the most conservative estimate. The real results are probably even better, I would say. So after treatment, somebody either gets a year of PRSS or no PRSS. And then after that year, some percent will be in recovery. This was operationalized as either sustained abstinence or sustained reduced substance use. Some percent will have returned to chaotic substance use, and some percent will have died. Those percentages are going to be different between those two groups, and those differences are what give us differences in costs and differences in our effects. And we looked at quality adjusted life years and number of people in recovery. Importantly, we looked at number of people in recovery at 3 years, because that's when that risk of returning back to chaotic substance use drops low and stabilizes pretty long term. It's stable after that point. It's not zero, but it does stabilize after that point. So I think pretty unsurprisingly, PRSS is cost effective no matter which way we look at it. If we look at it in terms of quality adjusted life years, or if we look at it in terms of people in recovery. Here are the specific ICERs, the specific results that I found. But again, we built that calculator so that you can get your own specific results. So this is just the general US picture. but you can use the calculator to get numbers for your own actual program. I did that probabilistic sensitivity analysis, looking at all that variation all at once. The way that we look at those results is about how much of the time over simulating it over 10,000 iterations. If we had 10,000 different programs with all the variation all across the country, about how often would they be cost effective? So it's 60 to 70% of the time to the lowest threshold, that's the cost of treatment, to almost every single time by the first of these government thresholds. So it's very cost effective, very often, kind of no matter which way you slice and dice it. In the one-way sensitivity analyses, just the key takeaways I think that are most important to highlight. It's cost effective across a ton of different scenarios, but also peer worker pay and service utilization. So how much each participant actually uses of the program, those actually don't have much of an impact on cost effectiveness. So there's no justification from a cost effectiveness standpoint for keeping peer worker pay low. Peer workers should be paid more. And then we also don't have any justification to limit service utilization. I haven't really heard much about that going on, but it definitely bears saying. There's no need to limit service use. But what does impact cost effectiveness a ton is the overall effectiveness of the program, right? So it kind of stands to reason that if peer workers are paid a little bit better, maybe have a bit better job satisfaction, they stay on the job longer, maybe they deliver better services, right? So we want to impact cost effectiveness by impacting the overall effectiveness of the program, making sure our providers are able to do their jobs well and deliver really good services, right? And you can download the full results if you want to look into all the details of this. If you want to see all of my formulas, go for it. All of that is available here. So totally an open book on that stuff. So that takes care of all of the background. We're going to talk about, that takes care of all of the PRSS part of it. We're going to talk about bystander naloxone distribution next. Very, very similar kind of approach. Of course, it's the same method. We updated an old study though. So we didn't have to do any of that background work that was already done. But we did have to update everything to 2019 numbers. And we used 2019 because, COVID has been really weird. So had a lot of weird economic impacts too. So 2019 is just a little bit more of a stable year compared to the COVID years. And again, similar kind of model, except when we are reversing an opioid overdose, we are not super worried at that moment about whether or not we can get that person into recovery tomorrow, right? Like that's not what we're trying to do. We're trying to save their life just in that moment. If recovery comes later, awesome, but that's not what we're worried about. So we don't include that in this model. So that's not part of this analysis. Just focusing on lives saved. Would be super cool to add that later. There's not a lot of good data on that yet, but hopefully that will be someday in the future. Okay, so let's pause right before we dive into the calculator. Any questions? Okay, so I am not going to walk through every single one of these because we're going to look at the calculator together, but I wanted all of this on a slide so that you could reference it later. These are the inputs you'll need for the peer recovery support services part of the calculator. All of the inputs are in line with Faces and Voices of Recovery's standards for PRSS accreditation. So they're numbers that should be gettable. And then the RCOs that we talked to said that they were pretty gettable. You might have to sit down though and do a little bit of math. So like I'll give you the example of if you don't pay your peer workers hourly, pay them on a salary, that's not untypical, right? You might have to convert that into hourly. I gave you a quick little rundown on how to do that. But of course, email me if you have any questions or run into any problems, right? Here are the inputs you're going to need for naloxone. We definitely know we need to change a couple of the inputs. So it's just notes on that, but we'll take a look at that in a second here. Okay, so again, those are for your reference, so you have them. Let's dive into looking at the calculator. So this should just work. There's my beautiful sun again. I'm going to get my browser pulled up here. Okay. So you can feel free to go to the calculator yourself as well and follow along if you'd like. But I'm also happy to just walk through this way. Okay. So here are those inputs. Let me give you a kind of quick high-level overview first. So we've got our PRSS tab, we've got our naloxone tab, and then over here we have a tutorial and resources. Here is that longer webinar I mentioned, and the presentation slides for that are here. Our contact info is here, and then feedback. We would love to get your feedback if you want to leave any. So you can follow that link here. And then a shout out to the 2 RCOs that helped. Okay. So we can either use default values or enter your own numbers. You can also do a combination of the 2, which is pretty cool. So I'm going to hit default first while we walk through it. The first input is how many people served. When in doubt, think of 1 year. We're talking about on your average year. So let's say my organization actually tends to serve more like 200 people a year for long-term peer recovery support services. What percentage are retained to either 1 year or to successful completion of long-term peer recovery support services? And for you, that might be 6 months, that might be 9 months, might be more like 4 months, whatever that number is for you, as long as it's long-term and we're not talking about like one-off interactions or like linking somebody to care, but then it's not an ongoing relationship. So what percent make it to that successful completion or to about a year? Let's say your average is like more like 5 years in the interaction, right? You don't need to worry about that. Not everybody's going to make it to 5 years. Set that cutoff for 1 year. So let's say ours is a little bit lower and we're at 60%. Of those retained, what percentage of participants are still in recovery at graduation or at 1 year or completing, right? So, and again, use the definition of recovery or success that your organization uses. Ours is, ours that went into our analysis is based on either abstinence or reduced sustained use, where the person still self-defines as in recovery, right? So let's say ours is a little lower as well. Let's drop down to 75. Average age participants. Let's say my organization does not track age. So I actually don't know. So I'm going to use that default value. What's the average number of engagements? Oh, I'm sorry. One quick note about average age. You'll see this little note here. We can actually only take between 20 and 54 right now. If you serve mostly young people, I apologize, just enter 20. That's as close as we can get. But it's just because every 5-year grouping of numbers requires its own set of like 1,000 cells, Excel cells of calculations. So so we could only accomplish that many in this the year that we had to build this, right? So sorry. But when we get more funding to build out more comprehensive versions of this, we'll definitely have a broader age range. But yeah, so let's say I don't know. I'm going to use the default. Okay, this is where it can get a little bit tricky. But this was the feedback I got was that this is okay, it's doable, but definitely a little bit weird. So number of engagements. How many times did a participant meet with their peer worker, right? Over the course of their long-term peer recovery support services. And then how long were each of those sessions on average? So definitely some are probably going to be 5 minutes and some might be 2 hours, right? What's the average? You don't have to average within an individual. An average across the whole organization is fine. And some of the common like data platforms that people have been using do tend to track this. So hopefully that is something that you have access to, or your evaluator or somebody who you work with to kind of work with your data can get this. If not, just use the default, right? That's why they're there. The default numbers come from studies of multiple recovery community organizations too, right? So delivering peer recovery support services. So they're pretty good. What is the hourly pay for peer workers at your organization? And you'd want to include fringe in this as well. And let's say it's more like, you know, I'm in Texas, they don't pay peer workers particularly well here. So let's say it's 20. Then we just hit submit. And you'll see here, there's two perspectives. And again, it's tabs. So we have our societal perspective, that's that global view. And we have health system perspective, that's that narrower view. We have some interesting numbers at the top, but the actual ICERs, those like that result that we're looking for is down here. See, ICERs. And it tells you in plain language, is it cost effective to this threshold? Is it cost saving as well? It'll say yes or no. And then it'll give you the actual numbers. Up here, the stuff I just skipped over, these are interesting numbers that you might find useful in like a grant proposal. Here's the total averted cost to society as the result of this specific program that I just plugged in the numbers for. Here are how many additional years of life we're adding that are quality adjusted. Here's the number of people in recovery that we have that you wouldn't have if you only gave people treatment, right? And then this little bar over here, I think is pretty cool. This is why it's so nice to have that quality adjusted life year for comparison. This actually puts your result, your quality result, in perspective to a bunch of other types of health interventions that people have heard of, right? So they're generally accepted as like pretty good things. So like lung transplants, right? So it puts your numbers into context. And you'll notice here, let's change our peer worker pay to $50, right? You'll notice that when these numbers change, the dial goes up and changes as well. Very similar setup on the health system side. The interesting results that are pulled out are different. The ICER, that result setup is the same. This little bar over here is the same. And then our naloxone side is a lot simpler, right? Again, we're not looking at recovery. It's a much simpler intervention. Do you get the naloxone or not? And then we know we're trying to work on the wording for this, but let's say we want every single person that walks through our doors to get naloxone. We assume that 20% of them already have it. So that's why we only put 80% to make 100. And then let's say I got a special deal and I get naloxone for $50 a pop. I submit that. I don't know why it's not working. Let's try that one more time. There we go. I don't know why it wasn't taking that, but I kind of live in the country, so sorry. My Wi-Fi is not always great. And it's a little simpler of a display too. It's only health system perspective. And it is, I mean, it's kind of, naloxone distribution is kind of a no-brainer. It's very cost effective, costs very little for every life that it saves. Okay. So I know we're right up against the hour. I really appreciate your time today. Are there any questions or comments?
Can I run one through with you?
Yeah, absolutely. I don't know if maybe we want to hang on to when we're officially done and we can do it in the 15-minute break.
Okay.
Yeah. All right. Any other questions?
Sierra, I actually think you have until 1:45.
Oh, cool. Okay. So then, yes, we can go ahead and run it through.
Yeah, I would love to see it, me personally.
Great.
So
I want to do the recovery retreat.
Great.
And Jessica used to run that. So you have
right.
2/5 of the people here interested in this.
Great.
So,
okay.
So we.
Siri here. Let me know if I can help.
Oh, I'm sorry. Can you hear me?
I just heard you. All right. So let's go to the PRSS because we don't do naltrexone. Okay. So Jessica, how many people do we serve in a year?
Gosh, I don't know if I could.
117?
No, 160. We did.
160.
Okay, 160. And what portion of those went the full 2 weeks or finished at the end? They don't have to come who didn't leave early. Just a guess.
Gosh, maybe like 70%.
Cool.
75.
Yeah, I think it's probably closer to 75.
Great.
Yeah. Most people do, just maybe I'm thinking the end actually. So maybe actually I would put 80 because a lot of people at the beginning went for the full session.
Cool.
Yeah. Okay. All right. So what percentage of participants are still in recovery at graduation? So how is that different from the 80% up above?
So who participates the whole time? And then of those who participate the whole time, who is still in recovery at the end? So somebody may still be participating, but they're struggling a bunch. They're in active substance use. So we wouldn't count them as in recovery, but we would count them as retained, right?
I see. Okay. So Jessica, where are we on that?
75, I would say.
75.
Yeah,
Okay.
very little.
And then our average age of participants is probably higher than 38 because we have more seniors involved. What do you think that might be? 45 average age?
Yeah, 45 is, I would say that sounds right.
Also,
though, the 75%, am I creating a percentage out of only that 80%?
Nope,
no.
It's of those. So you wouldn't need to so you're referring back to just the, just that group that's retained. So if it's 75% of those retained, we're not asking about the percent of all of your participants because we've already narrowed it down. Does that make sense?
Right. Yeah. So then I would say that number is like 95% or 90% because it was very little that weren't in recovery, but stayed the whole time.
Yeah. Yeah.
Okay.
Yeah. Typically, it's not unusual to only stick around if you're still in recovery, right? Yeah.
Yeah.
That's why we wanted to split those apart, right? Because it isn't as useful of a question to say how many are in recovery by the end, because well, who's still there at the end, right?
Yeah.
We need to make sure that we're accounting for that first.
Yeah. Okay. Nice. Okay. So what is the average number of engagements that your participants have?
So they're there for 2 weeks.
Okay.
24/7, but they're sleeping at night. We're not engaging with them. So so that would be 16 times, is it 13 days? So 208 hours.
Okay. Is that right? So if it's 2 weeks, but it's 13 days, 13 days, and then roughly 8 hours of direct engagement that whole time?
Or is it, I think it's probably more than that. Is that right? Because when do we first start stuff with them? At 8 a.m., Jessica, and they go until 10 at night?
Yes.
So it's 12, so it's 14 hours a day.
Okay.
14 times 13 days equals 182.
Great.
Okay.
182, and then easy peasy, we can just say an hour, right?
Right. And we're trying to pay, so, let me find out what we're paying here. We're paying So we're paying 26.84, including all the benefits. Okay.
Great. Great. So let's take a look. So it's cost effective. Yep, it's cost effective to all of the government thresholds. It's not cost effective compared to the cost of another specialty treatment episode, but it's not that far off.
Okay.
It's saving almost $400,000 in societal costs across the whole intervention. And if you do it by per person, that is $2,400 per person. Let's see. Yeah, it's adding 54 years of life, quality adjusted life years. 28 more people are in recovery compared to if they had just gone to treatment. And then if we come over here to the health system perspective, so that's that narrower view, this is how much it's saving total in medical costs, averted medical costs, per person, averted medical costs. These two are the same, quality adjusted life years and people retained in recovery. But then here's our cost effectiveness ratios. And in the medical in healthcare costs, the health system perspective, it is cost effective to all of the thresholds.
But it's not cost saving.
It's not cost saving, no. But remember that it doesn't need to be cost saving to be cost effective.
Okay.
And this is the most conservative way of estimating it, because we're talking about it in comparison with specialty treatment, which has an effect. It is kind of the top of the line, right? We know most people don't get that. So if we were able, when we extend this out, to be able to be a little bit more subtle about like, where are people actually coming from? They're not always coming from treatment. When we're able to incorporate a little bit more of that subtlety, then we might see stuff start to tip over into cost saving as well, but it is cost effective.
Okay. Jessica's program took people straight off the street.
Yeah.
Who were using or had severe mental health issues. Now, because we'll have people in our stuff who have severe mental health issues, but aren't using substances. So that's going to be skewed because you're dealing straight with substances. Okay, but this is really, really helpful. I love it. I love it.
I also want to say, like, if you hear of anybody who wants to take this, like, what would have to happen to make it suitable for mental health primary care services would be, you could use basically all of the same ways that all of the formulas that we've set up, but you'd have to just plug in different numbers to do the background calculations, because it would be based on like a different set of outcomes, right? But I am more than happy to like give everything somebody who wants to do that work. They can have all of it. I'm happy to collaborate with them on that. So yeah.
How long do you think that would take?
We did this in a year, probably a little bit less than a year. So it probably would take, if they had the time for it set aside, they could do it in 3 to 6 months, probably, since so much of the groundwork is already laid.
Okay. Yeah. So, and then I had another question that we could go through, Jessica, and just do the people using substance use that come in, and that would help us with grant stuff and whatever. Yeah. This is super cool.
Great. And do feel free to email if you have any questions or run into any issues, or like if you want to I'm happy to read over, like, if you want me to look at the paragraphs where you talk about the results, happy to do that.
I'd never heard of cost savings versus cost effective, because we have another program that is hugely cost savings.
Yeah.
And we always write about it being cost effective, and we need to get that other. So I love your incremental cost effectiveness ratio.
Yeah.
I'm going to be using that a lot in grants coming up.
Good. The way that I kind of think about the difference between just looking at cost savings. So you may have heard of like, what's the cost, the total cost of the problem, the cost of an intervention, and then there's cost savings, right? That's really just subtracting those two things. It is not quite the same as dividing, right? As that true like cost per ounce, or even like the ratio of benefits to costs, right? So when we cross over into division, right, any of those three methods that I highlighted at the top, that's when we're looking at efficiency, right? We're truly able to say something about efficiency. Cost savings is still a lot of great information, but it is not quite the same as how efficient is our program, right? Does that make sense?
Mm-hmm.
Yeah. So it's just more information, and it's not like, it's not, other than the grocery store, we don't really encounter a lot of other things like that in our daily lives. So it can be a little bit unintuitive, but hopefully this was helpful.
Very helpful.
Great.
And I love how you quantify good stuff.
Yes. Yes. Yeah. Trying to avoid jargon wherever I can.
Yeah, it's a very complex calculator, but once you can get it down, it's really effective, like it's actually really cool. I would love to do those numbers, Ruth. And I think we have we track pretty accurate data that we can have really accurate results from the calculator.
Excellent.
And yeah, we should totally do it.
Excellent. Yeah,
that's awesome. Very nice. Good job.
And if there's anything I can help with, just let me know. So thank you.
Cool.
Great.
Yeah. Okay, so nice. All right. So it's Zoom, so we can't really applaud you, but I really, really want to thank Sierra for being here and for presenting on this. This is really amazing data, and we have this recorded. So what's really great is that you also have a tutorial, but if people want to go back and watch this recording, they can, to kind of get a little bit more familiar with the material. And so again, if anyone would like a certificate, you are more than welcome to put your name and your email in the chat. And I will save the chat at the end of this session. So I'm going to go ahead and share my screen. So in this particular room, we have a 2:00 presentation. It is by me, yours truly. I will be the one presenting on what is transference and transference in the workplace. So if you would like to come to that, you are more than welcome to stay in this room or just come back. I shared the link to this PDF. So if anyone here is interested in any of these other 2:00 presentations, they can just open that PDF, and all of these little colored boxes with the Zoom names and the meeting IDs are clickable. So you can just click on it and it'll bring you right to another Zoom room. Again, I just want to thank Sierra one more time. That was really detailed and really awesome, very informational. And I'm so thankful that you came and presented on this today. So thank you again.
Thank you so much for having me. Appreciate it. All right. Bye.
Bye-bye. Thank you so much.
That is very cool.
Isn't that very cool?
Yeah.
And the question is, can we do something similar for collaborative housing? But wasn't that cool how quickly we could do it for the retreats? And we can use that.
Yeah. Oh yeah. It's just genius. I think it'd be really cool if we could do it for our housing.
Right. Well, I think we need to do it for mental health and homelessness. We got to find some sort of way of getting the numbers put together. And I'm wondering if the Economic Roundtable would want to do that. as somebody to collaborate with Sierra.
Yeah. Oh, that would be cool.
Yeah.
Yeah, wow, that's really good. I'm surprised not many people came, because that was good information right there.
Right. Well, there are lots of places to go to for each one. And because they're, you know,
All at the same time.
yeah, they're all at the same time. So if you take, and I don't know how many total people are in at any one time, you know.
Right. Yeah.
So.
Yeah, there's 8 rooms all at once and all good material and good presenters.
Yep. So I've already seen your transference thing, and it is excellent for
All
anyone
right.
who doesn't know better. And so I recommend people saying, I've got to get off and do other stuff because I've got to work. But thank you, Jessica, and good luck with transference. And
Thanks.
it was a good session. Take care. Bye-bye.
Okay, take care. Bye.